Hi, my topic today is going to be on a unique pain management treatment for Ehlers-Danlos patients, a manual therapy approach. When I'm talking about manual therapy, I'm talking about, in the United States, physical therapy. Here in Canada, it's called physiotherapy and osteopathy. In the United States, an osteopath is equivalent to an MD. In all other countries, an osteopath is not. There are high-trained manual therapists in Canada as well as in Europe. But in the United States, an osteopath is equivalent to an MD. I do have an osteopathic degree from Canada, so I'm not an osteopath in the United States. I just have an osteopathic degree in Canada, as well as a physical therapy degree in the United States. So when I'm in America, I don't call myself an osteopath because I don't want the osteopaths to put a cease and disorder against my practice. So I practice physical therapy in the United States. All right. So what I'm going to talk about today is some principles on what I do as a physical therapist and how I treat the patient. Before I sent in my memory stick to Sandy, she didn't ask me for the bio, so my bio's up there, so I'm just going to scroll through the first two pages. But importantly, I've been trained by two world-renowned osteopaths in the United States, a Dr. Annie Wales, who was a practicing American osteopath in the 1920s, 30s, and 40s and 50s. And she trained me from the stuff that she learned from William Garner Sutherland, who is the architect of what we know now as of craniosacral therapy. And Dr. Stephen Sannett, who is another American osteopath that trained me in American osteopathy as well. It's just my education. When I was studying my paper, I had quite a few EDS patients in my clinic, in my practice right now. Quite a few of them are actually from Dr. Henderson. And when I was doing my presentation, or setting up my presentation for what I did in Rhode Island about a month ago, and Dr. Frank Amano was there, the first picture I took, my patient did this. She said, "I'm having a bad EDS day, and I want to be the poster child for EDS." So that's why the picture's that way. Ehlers-Danlos is a group of inherited connective tissue disorders caused by various deficits in the synthesis of collagen. The research indicates that it occurs 1 in 2,500 to 1 in 5,000, and you'll also see in some research it says 1 in 10,000. It is also known to affect both men and women of all racial and ethnic backgrounds. There are 6 distinct types, and I'm going to be mainly talking about hypermobility, or what I like to call hyperlaxity. The hypermobility is actually secondary to the hyperlaxity of the ligaments, or the collagen. All 6 types share joint laxity, soft skin, stretchy skin, easy bruising of the skin, and some systemic manifestations. Collagen and EDS. Collagen is the most abundant protein in the human body. Collagen, as Dr. Frank Amano and Dr. Guzman mentioned, performs structural strength of our human tissue, including our heart, blood vessels, eyes, skin, ligaments, muscles, collagen, and bone. When muscle, ligaments, and organs are built with defective collagen, they will become systemically weak and unstable. Some facts about connective tissue and fascia. 16% of our total body weight, 25% of the total body's water content, and the strength varies between 2,000 and 7,000 pounds of pressure per square inch. These 3 principles are how I treat all of my patients, not just my EDS patients. And these are the founding principle of osteopathy by Dr. A.T. Stills back in the 1800s. A.T. Still was the founder of American osteopathy, but before that, he was an MD and a surgeon in the Civil War. He said, you must treat the body as a unit. When we're treating our patients with connective tissue disorders, EDS, joint hypermobility, we can't just look at, oh, my shoulder's sore today. You've got to look at their entire body and treat the whole patient, not just the symptoms. Because if you start treating the patient's symptoms, you'll be like a dog chasing your tail running around. So it's important to treat the whole patient. Structure equals function. If the joints are subluxed or dislocated and you try and exercise those patients, they will not function very well. They'll have difficulty walking. They'll have difficulty moving their arms and their legs. The body also poses its own mechanism for repair and to restore health. How muscles and ligaments function, from my standpoint, doing physical therapy with these patients. Muscles should be off tension until we actively contract them to move a body part. Ligaments should always be on tension to stabilize the joint and the bones. As we know, there are 206 bones in the body and 602 muscles in the body. So if you're dyslexic, you can flip the numbers around quite easily to remember them. How I see EDS and hypermobility, it's just the opposite of what should happen. The muscles are on tension in an attempt to stabilize the joints, which in turn cause pain, muscle spasms, and trigger points. Because when a muscle stays on tension for a long period of time, it's going to compress the blood vessels, and it's going to compress the nerves that are in them. And so that's why you're going to get some impingements and some burning sensation, some paresthesia with the patients as well. In turn, the ligaments go off tension, which cause joint pain, instability, subluxations, and dislocations, which cause irritation to the cartilage of the joints, the meniscus, the discs, and as Dr. Francomano was saying in her lecture yesterday, the arthritis that they've been seeing in the spines of the patients are what I'm assuming from my presentation here is the cause and effect. So manual physical therapy, osteopathy, or physiotherapy here in Canada, our goal is to reverse this process and put muscles off tension and put the ligaments on tension. Once the structures are balanced, therapeutic strengthening or toning exercises as well as stabilization exercises are used or introduced, as well as some specific stretching exercises for those muscles that are in spasm or have trigger points to them. I've had some physicians tell me that they do not want me stretching their EDS patients. That is true for the most part because there is a joint laxity. But you also remember there is an antagonistic muscle and an agonist muscle. When one of those muscles go weak, the other one has to become too tight or strengthened to balance the joint off, and in turn will potentially pull the joint out of alignment. So when those muscles shorten, we must also stretch them or break their spasm or break their muscle trigger point. These are a bunch of different laundry list of manual physical therapy or physiotherapy or osteopathic techniques that we can utilize while we're treating patients. The first one is a direct technique. I do some joint mobilizations with my EDS patients, particularly if their joint is stuck out of alignment, so I need to get it back in place. However, I guard against anybody doing joint manipulations with these patients because you can cause some serious harm, especially with their ligaments being weak. And if there's anybody that does any joint manipulations to the patient's necks that are unstable, please do not do that. I've had some chiropractors in the United States doing joint manipulations to the patient's necks that actually had cranial cervical instability, and it didn't turn out very well. Indirect techniques are basically myofascial release, cranial psychotherapy techniques, and you're going in the direction of ease of the soft tissue to try and help it relax more, break some of the muscle spasms or the trigger points. Soft tissue massage or mobilization, lymphatic drainage. I do a lot of cranial psychotherapy with my patients in the United States that I'm treating with EDS. Functional facilitated position releases. I do a lot of functional techniques with the patients. I do a lot of postural re-education things with them, a lot of things in sitting or standing because they need to be able to function in that position. You can't function and treat the patient lying down all day because it's in a gravity eliminated position, and we have to function, as we know, standing erect in a gravity position. I do a lot of myofascial release, some ligamentous articular release, a lot of muscle energy techniques with these patients, but you got to guard against what you're doing with the muscle energy with them, especially if you're going over more than one joint, if you're doing 2 joints at a time. Jones strain, counter strain techniques, and I do a lot of visceral mobilization or manipulation with the patients, particularly with their intestines, because as we remember, the intestines are made up of smooth muscle, and smooth muscle is contractile tissue, and soft tissue can go into spasms or have trigger points, which will also make their valves not work as well. So I do a lot of visceral mobilization and manipulation with them as well. Now I want to talk about the treatments that I do. I'm going to show you some before and after pictures of the patients that I've treated and how I've gone about treating them. But I will caution you that some of these treatments, you have to be highly skilled at what you're doing. I just don't want somebody to do it without knowing what they're doing because they actually could cause a lot of harm to these patients. This young lady is a college student, and she finished her freshman year last year at Providence College, which is basically a Jesuit educational Catholic university in Rhode Island. She's from Massachusetts. She is one of Dr. Henderson's patients. Her name is Nicole. She is an electric wheelchair. When she first saw me, she was able to walk about 10 yards, maybe 15 yards. Now she can walk probably about 100 to 150 yards with a walker and sometimes with a cane. But she utilizes her electric wheelchair to get around school. And she was able to finish her entire freshman year at Providence College and maintain a 4.0 average, which is pretty impressive. This is a frontal look at how she looked before the treatment. And now I'm just going to show you an osteopathic treatment that I did with her or a manual therapy treatment that I did with her. This first technique is I'm doing a rib release. I'm going to treat her entire body. I'm not just going to treat one joint. So I'm releasing her ribs in a very specific way. I'm doing a SIJ decompression, a sacroiliac joint decompression. I'm moving the ilium away from the sacrum, nice and gently. As you can see, her hands are resting on her belly. I'm having her do some diaphragmatic breathing, which will help in the release because the patient's relaxing. It's increasing some blood flow and oxygenation to the tissues. This is a pelvic floor release, very basic pelvic floor release. A diaphragm release. A thoracic inlet release. A right shoulder decompression. A hyoid release to allow her to swallow a little bit better and stand up straighter and help with her forward head posture. Now I'm doing some cranial sacral therapy. This is called a classic claw grip to mobilize her frontal bone. This is another frontal bone release. A parietal bone release. A sphenoid release. I'm treating her temporal bones in this position here. Her TMJ, it's a TMJ decompression. Frontal nasal suture release to help with her breathing a little bit better. I'm trying to, when I work with my patients, I try and get them to breathe through their nose and out their mouth so that they can breathe better and that their blood pressure will be better as they're standing more erect. A lot of my patients, I find when they stand up, they purse lip breathe, they breathe through their mouth instead of through their nose. And I'm also having her work on some diaphragmatic breathing with her hands on her stomach while I'm doing that. This next technique is I'm just finishing up and doing a nice relaxing treatment to her forehead to allow her to relax a little bit more. It's called the tapping technique that I learned from Dr. Sannett. My left hand is under her occiput. My right hand is on her sacrum. This is called lumbosacral rocking. And I'm releasing her entire spinal cord in hopes to increase some cerebral spinal fluid flow and allow her to have less pain throughout her entire spine. She was also having some issues with her right elbow. She has a lot of difficulty writing, so she uses a Dragon software in college. And so I'm just doing a little bit of treatment here because she had to do some writing at school that day and had to do a lot of typing. So she wanted me to treat her elbow and her hand, which I did do. I'm releasing her radius in that position there. So this is the post-treatment, how she looked compared to the first one. I'm going to show you a comparison of both. That's the frontal look, but that's the before and after. And the treatment took about 20 to 30 minutes. And that's the frontal look. And Dr. Hennison, you may recognize her. She's one of your patients, Nicole. And I'm going to show you some basic exercises that I started with her. These exercises, when I start with my EDS patients or my hypermobile patients, I may start with one exercise. I don't do a lot of exercise with them. If you ask your patients who have Ehlers-Danlos how many of them failed physical therapy or physiotherapy, a lot of them are going to raise their hand and say, yeah, I don't want to go back. What happens is, in physical therapy, we're trying to exercise the patient to get them stronger or more toned or more range of motion, more functionality. We don't know a lot about EDS. I didn't learn anything on it in physical therapy school back in the States. And when I did my osteopathy here in Canada, I didn't learn anything on it either. I just learned how to treat some hypermobile patients from school. So when I start with the patients, as I said, I do maybe 1 or 2 exercises, and I'll do low reps to start, just to make sure that they don't sublux their joints while they're doing those exercises. I always treat the patient first with my hands, doing the manual therapy, and then I'll have them do exercises. Why? To go back to the principles. The body is a unit, and structure equals function. So if the structure is aligned, and you start to exercise patients, they will tolerate it a lot better. It's called the clam exercise. She's strengthening her hips. That's the beginning position of it. And there you can see a picture of her electric wheelchair. And she's doing some adduction to strengthen isometrically her leg muscles. She's doing some ball squeezes with some bridging to strengthen her core. And I ended the treatment with her just to decompress her low back. We put the patient's leg up on a chair or on a ball and just have them do some diaphragmatic breathing. And that will relax the whole lumbosacral spine and the entire spine. And when she gets up, she feels a lot better. It's another patient. I'm just doing an assessment of her lumbosacral spine as well as her sacroiliac joint. And this is one of the patients that has EDS that has some hypermobility, but not a significant amount. So as you can see, I'm doing a muscle energy technique for her L5. My right thigh is under her knee to protect her knee, and she's gently pushing down with her right foot into my left hand, and I'm able to mobilize L5 into place. It's basically an isometric contraction to move the bone back into place. Now, with my EDS patients that have a lot of joint hypermobility, I wouldn't do this technique because I could potentially pop out their knee, potentially pop out their hip. But the resistance is very light. You're only using a couple pounds of pressure, okay? And the patients doing the resistance, I'm just preventing them from moving through it. It's another technique for muscle energy, and I'm fixing her sacroiliac joint in this position. She's pushing her bottom leg up into my hand. I am not pushing my hand down into her leg. I'm just meeting her pressure. And again, it's only a couple pounds of pressure. This is how I do a lot of my, if I can get this little movie to go, how I do a lot of my...
Does it have audio?
It's a little video.
Does it have audio with it?
No.
Okay.
Okay, how do I get it to go? I just pressed on it and it didn't go. Nope, that's not it. It's a little further up. It's a little further up. Further up. Further up. That one, that blank one, is 50. That's the technique we do for a lot of our more hypermobile patients. The patient wiggles on the table comfortably, and I just hold my hands on her sacrum, and it helps realign the patient's sacrum. It works really well. In this particular patient that I did that with, she did it a little faster. She's been coming to my clinic on and off for the past 15 years. As a patient, they didn't know what was wrong with her until recently she was diagnosed with EDS, and she's had approximately 25 surgeries in the last 15 years or so. And that technique works really well on her. This is another muscle energy technique. It's for a right upslip. My left hand is above her knee, my right hand's below. She was very stable, so I was able to put my hand above and below the joint. A lot of times with my more hypermobile patients, I'll keep both of my hands above the knee so there's no pressure on the knee. And I have her abduct her leg and make her leg longer, which fixes her short leg if they have a upslip. This is a lumbosacral decompression. My left hand is stabilizing her lumbar spine between the spinous processes, and my right hand is on her sacrum, and I'm doing a gentle caudal glide towards her feet as she's doing some diaphragmatic breathing. Just a sacral decompression. My hand's on her sacrum at a 90-degree angle and just gently tractioning down towards her feet. My right hand is on her sacrum. My left hand is on her ASISs, both laterally, and I'm squeezing them together medially, which will gap her PSISs, or her posterior superior iliac spines in the back, to gap her SI joint as I free up her sacrum. As we know, with our patients that have sacroiliac joint problems or iliosacral joint problems, the sacroiliac joint is a physiological joint. It means when you walk, it moves in and out of alignment. It's supposed to move symmetrically. With our patients with EDS or our patients with sacroiliac joint issues, their sacrum gets locked in position, so they're not able to move the sacrum through the full position. So they're going to have decreased basis of support when they're walking, or sometimes increased basis of support, shorter stride lengths, and a lot of pain with walking. So by gapping the joint and getting it to go into place, they can walk more symmetrically and have less pain with standing and walking. This is a pelvic floor release. My right hand is on the sacrum and my left hand is on her pelvic floor. Ideally, my right hand would have been on her stomach instead of my left hand, because you want your little pinky going down towards the patient's private areas. You don't want your thumb going down in that area for some potential uncomfortable situations. But just for photography-wise, my person who was taking the pictures was in the room, and she just started snapping pictures, because I was also setting this up for the Rhode Island lecture I did for the EDS conference about a month ago. This is one of the functional techniques I told you about. the patient's sitting on her ischial tuberosities, I'm going to have her rotate right and left, and I'm going to follow her legs with my hands to see how it moves. And I'm looking for symmetrical motion of her hips and her legs. As she turns to the right, her lumbar spine should turn, her thoracic spine should turn to the right, her sacrum should turn to the left, her right leg should shorten, her left leg should elongate. Then I'll have her do the same thing to the opposite side. And if I'm finding one side to be not symmetrical or unsymmetrical, I will hold that position until it releases. And then I'll have it bend forward and go back up. And she felt a lot better after we did the technique. I'm doing a Jones strain, counter strain technique here. My left hand is not tractioning her arm. It's just holding it in place because if I traction it, it can potentially sublux or dislocate her shoulder and her wrist. My right hand is doing the work on her subscapularis. It's a Jones strain, counter strain technique. Shoulder decompression. A supraspinatus with my left hand and a subscapularis with my right hand. And as you can see, my hands are going in opposite directions. I'm doing an oppositional trigger point release to her rotator cuff muscle. She came into the office with the shoulder like this, so I wanted to get her shoulder back in position, so I helped move it that way. This is another Jones strain, counter strain technique for the supraspinatus. This works well on a lot of my rotator cuff patients that have EDS, some impingement syndromes, the techniques that I just did with their brachial plexus or with some of their cervical nerve roots. That's how she looked after the treatment. Unfortunately, I did not have a picture before. This is Ellen. She talked with both you, Dr. Francomano, and Dr. Hennison at the Rhode Island conference. She's wearing a strap around her shoulders. We usually, in the past, would put patients in those if they had fractured clavicles, but her doctor put her in it because she does this when she stands. They were just trying to get her to stand more erect, and she has a left shoulder that subluxes and dislocates on her. And that's the side view. I didn't treat her upper body on this day. She came in and I treated her, both of her legs, and I'm just going to show the treatments that I did with her knees and her ankles and how she stood after. This is a tibula-fibula release. I'm balancing off both the proximal and distal fibula. I'm decompressing or deloading her tibia that was externally rotated. I'm balancing off her kneecap because her kneecap was laterally dynamically glided with an external rotation, which caused her to have some chondromalacia, what we used to say in the olden days, now is called patellofemoral syndrome. I'm balancing her hind foot on her forefoot. I'm balancing off her cuboid here. I don't have the next picture, but the next picture should be showing me balancing off her navicula. I'm balancing off both her navicular and her cuboid in this position to give her a little bit better arch when she goes to stand up. And I'm just bouncing off each one of her metatarsals in her foot. And that's how she looked after the treatment. And the treatment took 20 minutes to a half an hour max without the shoulder straps on. And she's standing up perfectly. And that's the side view. Before and after. Before and after. I also do a lot of TMJ and a lot of cranial. So sometimes I have to go inside the patient's mouth if they're getting, their jaw is not occluding correctly, or they're having some muscle spasms in their pterygoids in their mouth or their masseters, their suprahyoid muscles. I'll go inside the mouth and do some treatments, and I'll do some cranial inside the mouth as well, some cranial psychotherapy. Just another picture of me doing some cranial. Another picture. Another picture releasing the base of the tongue muscles in her mouth. A before and after picture. This is that young girl I showed you earlier. This young lady, her name is Victoria. She missed an entire year of school prior to seeing me, and somehow she was sent to my office. She finished her junior year of high school and hardly missed any days of school by coming to therapy. And her senior year, which is this year, she was able to go back to playing tennis at a high level, and she became the #2 tennis player on a girls' varsity tennis team at her high school. So some of the therapeutic stabilization and or strengthening, what I like to call toning exercises, because with our EDS patients, we don't want to get our EDS patients all bulky. We want to increase the tone of their muscles to help stabilize their joints and take some of the compression off the joints. Now again, I want to stipulate that some of these exercises that are in here, they're more advanced, because those were the patients that I was actually treating when I set up this presentation. I would start off much slower and with no weights. Some of these patients you're going to see actually lifting some weights to increase their tone. Okay? It's another patient well known to Dr. Hennison, and I also believe Dr. Francomano. This is Amanda. She's doing some cervical isometric exercises to help strengthen her neck, very gently. And this is to show you that an obese Ehlers-Danlos patient can actually exercise. She's doing some bridging, some straight leg raising, some hip adduction to strengthen her inner thighs, some short arc quads to strengthen her muscles in her thighs, particularly her VMO, vastus medialis, long arc quads, some hip strengthening, abduction, and next picture should be extension, but I didn't have time for that picture. This is Tori again. A lot of my patients come in a slouch position. We came up with an exercise to help them sit up straight, which takes minimal to no effort. But with that, you've got to make sure that their shoulders don't sublux or dislocate when they're doing this. If they do, they cannot do this exercise. I have her sit up, put her hands together, lift her hands up over her head, turn her knuckles towards each other, bring her elbows back and down, and that's how she's sitting after. 1 rep, that's what it took to get her in the right position. Because a lot of times when we tell our patients to stand up straight or sit up straight, tuck your chin in, they don't know what you're talking about. So I just have them do this, and the muscles help retrain her, or him. She's doing some strengthening exercises for her shoulders and her rotator cuff and her scapular stabilizers. Very light resistance. Light resistance, and the goal is to increase the reps. When you want to build strength, it's heavy weight, low reps. When you want to build tone, you want to do light resistance and more reps. But in the beginning, you're going to do little to no resistance and low reps and build yourself up with the reps with these patients. This is Ellen, another patient that Dr. Francomano and Dr. Hennison interviewed at the conference in Rhode Island. She's doing some lightweight strengthening of her shoulders. I am not going to allow her to go above 90 degrees because we don't want to go in an impingement position of her shoulders. She's doing some shoulder abduction, some shoulder flexion, and some scaptation. This one's scaptation to strengthen her rotator cuff, particularly her supraspinatus. Bicep curls, some hip exercises to strengthen her hips, hip extension with the neck supported. As Dr. Guzman was saying earlier, we have to do some cardiovascular training with these patients. We do that in my clinic. If they have a bad back, then they would sit on the bikes in the back that have back support. I don't like to put the patients on treadmills because of their dysautonomia, and that could be a bad result. So they have to sit. This is a high-level exercise, and this guy's name is Anthony. He was at the Rhode Island conference as well. He progressed really well. He's a young man who's probably about 14 or 15 years old. The only thing I do not like in this picture is the therapist that was working with him did not have him tie his shoes. They should be tied to help maintain his ankle proprioception so he doesn't lose his balance. Fortunately, he had good balance. One-legged on a Bosu ball. That's an air ball that's moving on the floor underneath him. So you have to have incredible core strength to do this. So we worked on a lot of core strength with him. Now they're doing one leg standing with ball tosses. So you can work on proprioception, hand-eye coordination, and standing up. So if you go to fall, you can catch yourself. But a lot of these patients, they have issues with falling. And so if we can try and help them catch themselves before they fall, unless they have a complete syncopal episode, as Dr. Guzman was saying earlier today, then that's not going to help. He's doing some trunk rotation to work on more core strengthening. Obviously, he would have to be well aligned before he can do that. That's Maggie. That's Ellen's patient, who is a service dog. So I thought it was a good picture. And I hope I didn't bore you too much, because that's the end. I'd like to thank Sandy for allowing me to come, and one very important patient that actually brought me here today. She's in the top right-hand corner up there. Her name is Madison. She's from Canada. She came down to Rhode Island for the conference that we had in Rhode Island about a month ago. And as you know, we don't like to treat patients when they come into our country or when we're doing a conference, because there could be some legality issues with that. She talked me into treating her, so I did. She did really well after the treatment. She was able to drive home for 10 hours in the car. And when this conference was being put on, her mother contacted Sandy to have me come. And they picked me up at the airport, so I wanted to thank them as well. And she brought her 2 younger sisters with her to pick me up, and I was able to treat both of them last night here in the hotel. So it worked out really well. So I want to thank you for having me come and for them for having me come as well. Any questions?
Actually,
Yes.
just for a second, Jim, do you want to start doing your setup here with your folks so that we get the, because I know you had some setup you wanted to do, and then we'll do the questions while you do the setup.
Yeah.
Great, thanks. Sorry,
You
go ahead.
probably said I just missed it. Where's your practice at now?
I have 2 locations. They're both in Rhode Island. I don't know if you guys know about the United States, but Rhode Island is actually the smallest state in the country. And it's in the north. I have 2 locations, one in East Providence, Rhode Island, where I live, and I have a separate office in Cumberland, Rhode Island. I have 1 therapist in my Cumberland office that does treat EDS patients that I've trained, and I have 2 other therapists in my East Providence locations besides myself that I've trained in EDS, how to treat them. I do have about 15 physical therapists that work for me, though, and they treat the other variety of patients. And as Dr. Francomano and Dr. Henderson can attest to, before I started treating a lot of these EDS patients, I was working 8 hours a day treating patients. Now I'm working 12 to 14 hours a day because my caseload has drastically increased, especially since this EDS conference I did in Rhode Island. And they're not just located in Rhode Island where I'm treating these patients. I've treated a lady from Portugal, a lady from California, Texas, so they're flying in from all over the United States to get treatment because there's no real options for them, which is unfortunate. And that's why I'm hoping that today we're able to break some ground on that and expand the horizon for treatments. Yes?
How often would you be providing treatments? Like Girl Victoria, for example, how often would you see her?
It varies, depending on how far they live. Anywhere from once to twice a week. All right? And I won't see them back to back. If I'm going to see them twice a week, it would be Monday and Thursday or Tuesday and Friday, so their body has enough time to kind of recover. The other issue is a lot of these patients are traveling one way to see me, and it's an hour and a half to 2 hour car ride. So they're not just flying in and staying at a local hotel and getting treated. Like the lady in Portugal, when she flew in, she wanted me to see her every day. I wouldn't do that because it would be too much treatment. So I'd see her 2 to 3 times a week in that case, and then she would fly out when she felt more stable. But the patients that live near me, once a week, once every 2 weeks. I mean, once a week or once or twice a week. Yes, Dr. Francomano.
If somebody comes to see you from a distance, are you able to formulate a treatment plan that they could then take back to a local physical
Yes.
therapist? Is that an option?
What I have done is I do a complete physical therapy evaluation on them with the osteopathic modalities that they might have wrong with them, like a left-on-left sacral torsion, a facet pathology. I'll write those down for the therapist to see if they can look at. I will write up a treatment program that I've already done that's been successful for them and send it with them. I will also ask the therapist call me, and I can discuss with him or her over the telephone what worked, what didn't work, so they don't have to reinvent the wheel. So I've done that with a lot of patients as well. Yes, Dr. Henderson.
I think prior to surgery, I should probably be sending everyone up to you for an evaluation, see who might be treated conservatively. And what do you think about that? And also, even the ones that might need surgery, there's probably a lot of therapy that can be done preoperatively.
What I found with my patients that are not just Ehlers-Danlos patients or joint hypermobility patients, in the past, I've been a practicing physical therapist for 27 years. If we're able to teach the patients how to stand correctly, how to exercise correctly, how to get some strengthening in them before they have surgery, the surgery is usually more successful because they have more tone going into the surgery. And then they have better, hopefully better circulation and better oxygenation of their tissues. And I found the outcomes to be, clinically speaking, not because I don't have any ability to do any studies yet because I'm in my infancy stages with this, but I found that they've done better. Just as I have found on my non-EDS patients, if they've had surgery doing physical therapy before, they were able to walk better after with crutches or a walker, and they recovered faster in their physical therapy because they already had some strength going into it, and they understood what was expected of them in the rehab after. Okay. Yes?
Have you trained physiotherapists or osteopaths in other states or countries?
Unfortunately, no. I'm hoping to. Dr. Chopra, who both Dr. Francomano and Dr. Henderson know, he's in Rhode Island with me. He's a neuroanesthesiologist. He does a lot of injections. He's trying to get me to write a book. I just don't have time. He also wants me to do some conferences to train therapists, and I haven't had time to do that until now.
Yeah, we've been approached in Toronto by a few groups who are interested, but as a physician, I'm always a bit nervous when they don't have a lot of experience with these patients because of the joint instability. So, and I've heard from patients having gone to massage therapists where they've ended up worse off because they've been
Massaged
manipulated in a way that, yeah.
The key is finding the correct balance and finding the right therapist that's going to work with the patient, understanding structure versus function, and function doesn't equal structure. I have a lot of conversations with my patients. A patient that is very near and dear to Dr. Hennison, actually, Karen, Aurora's daughter, little blonde-headed girl, she loves wearing high heels. She's 13. She shouldn't be wearing high heels. She has Ehlers-Danlos and joint hypermobility. When she comes in after wearing her high heels, she's a mess. So fashion, in her case, is trying to equal function. So I have to talk to her about that and make sure she's not doing that. But to answer your question bluntly, there is one therapist that I'm hoping to meet tonight. He's an osteopath here in Oakville. I did my osteopathic training with him here in Canada. And I'm going to meet with him tonight, and I'm going to talk to him and see what he can do. And if he's able to do some of the stuff, I'm going to contact Sandy and then talk to him about getting his information. Yes?
Going back to the issue of frequency, do eventually the frequency decreases
Yes.
and the patient
Yes.
becomes more independent? Is
Yes.
this a treatment for an acute episode, moment that they then learn, or are these patients going to probably see you for life?
As you know, with the Ehlers-Danlos patients, they have ebb and flows. Sometimes they feel really good, sometimes they feel really bad. When they're feeling really bad and not doing well, I'm treating them more frequently. And when they're feeling good, I try and discharge them to a home exercise program until their function starts to decrease again, and then they have an exacerbation of their symptoms, and they have to come back and see me. Unfortunately, with the Ehlers-Danlos, and as we know right now, with the care that we're giving, it's a lifelong disease. So they're going to have times when they're functioning really well, and that's our goal, is to get them to be independent and as independent as possible and become productive individuals in society. So during their down times, I treat them more. During their up times, I try not to treat them and have them work on their home exercise program. But all of my patients are given home exercise programs to work on in between their visits or between when they stop therapy until when they have to come back.
And do you liaise with the exercise, like the PE teachers in schools? Because a lot of the patients are, if they go to school, then recess and physical exercise is always an issue.
What I have done, trying to get a phys ed teacher on the phone at a public school is near impossible. It's almost like trying to get a surgeon on the phone during a busy workday. It's not going to happen. So what I do is I actually write up a treatment protocol of what they can and can't do for their PE or their physical education at school, and I hand it to them signed with my letterhead on it and with my telephone number if they want to call me and talk to me. So that's the only way I can do it right now, because I can't directly get them on the phone. And also, when I get them directly on the phone, they don't always write things down. They're sometimes not paying attention, because remember, I don't know about here, but in the States, a PE teacher is seeing maybe 150 kids in a classroom at once. So trying to pick out one kid, it's near impossible. Yes?
Back to the PE teachers, and I do understand that the treatment will have to be individualized.
Yep.
But there are some common grounds. One of the things that the Marketing Association has done is they have a whole PDF document that's probably about 15 pages that kids can take to school, so that when parents are challenged by the PE teacher that they should be able to do ABC, they actually have something in writing that comes from a well-organized network, so which has some credibility. Would you be willing to start working on something like that for EDS, which wouldn't be specific to a single patient, but would give families some teeth when they go to school if the PE teacher says, no, you're 10, you're supposed to be able to do that. Well, they're clearly not.
That'd be something I'd be willing to work on with somebody here in Canada if that opportunity presents itself, yes. You're welcome. Any other questions?
Great, thanks very much.
Sorry, it went longer.